coming to the mechanism action of the Nsaids, as I had already told you. Good afternoon, students. So the membrane phospholipid is acted upon by the phospholipase A2, and the arachidonic acid gets diverted to two pathways, the generation of leukotrienes as well as the generation of prostaglandins. There are various types of prostaglandins which are found. PGE2, PGF2 alpha, as you know, latanoprost is a PGF2 alpha analog, and PGI2, which is prostacyclin, which is antiplatelet aggregatory, and thromboxane A2, which is platelet aggregatory in nature. The Nsaids, they inhibit the COX and they leave the leukotriene pathway uninterrupted. And I would like to point out one major side effect of these Nsaids is the association of aspirin-induced asthma. This can happen with any Nsaid because if you block the pathway of prostaglandin production, then automatically the products of the arachidonic acid pathway get diverted to the leukotriene pathway. And as you know that leukotrienes are mediators of bronchial inflammation and they contribute to the generation of bronchial asthma. This is actually a pseudo-allergic reaction. You know, at this point of time, we should understand what is the difference between allergic as well as pseudo-allergic reactions. Pseudo-allergic reactions are those reactions which are not antigen-antibody mediated, and they might mimic allergic reaction. There might be bronchospasm, but this reaction we say is a pseudo-allergic reaction because it is as a result of the diversion of the products of the arachidonic acid pathway to the leukotriene pathway. So this adverse effect can be very well explained by the mechanism action of the drug. So it belongs to an adverse drug reaction which is called type A, or augmented or understandable. Among all the Nsaids, paracetamol has the least risk of causing Nsaid-induced asthma or aspirin-induced asthma. This aspirin-induced asthma is more likely to be seen with ibuprofen, which is one of the Nsaids which is commonly used, and especially patients who are having different types of allergies, who have presence of nasal polyps. You know, these are the people who are more prone to develop aspirin-induced asthma. The incidence of occurrence is just 1%. But if you remember this diagram, you would not ever forget what is the reason for aspirin-induced asthma. Nsaids do have some beneficial effect on the joint inflammation as well because they reduce production of superoxide radicals. These are all its actions which are, you know, the spectrum is beyond just prostaglandin inhibition. So they induce apoptosis. They inhibit the expression of adhesion molecules, they decrease nitric oxide synthetase, and they decrease the production of pro-inflammatory cytokines to some extent, like tumor necrosis factor alpha, interleukin-1s, but more studies would be required in this direction. And they also modify the lymphocyte activity. Coming to the paracetamol, its mechanism of action is clear. I told you that it is a drug with a weak anti-inflammatory action. It has the most superior antipyretic action at a dose of 500 mg, and its analgesic action, earlier perceived to be with 500 mg, is now said that its analgesic action can be experienced very well between the doses of 650 mg to 1000 mg. As paracetamol or acetaminophen has been used as an analgesic, and it is one of the analgesics which is approved by the WHO for osteoarthritis, which is a degenerative joint disease, primarily because of its long history or a good safety profile. It can be given to elderly people. There is a risk of aspirin-induced asthma is very less risk of GIT intolerance is very less. as far as its anti-inflammatory action goes, that is a compromise, because wherever there is inflammation, there is always a peroxide-rich tone. And the ability of paracetamol to inhibit the COX enzyme, which is the enzyme in question, is affected if there is a peroxide-rich tone of the environment. So that is why its activity in a setting of inflammation decreases, although it is no less than the other NSAIDs as far as COX inhibition is concerned. And you know that sites of inflammation contain increased concentration of leukocyte-generated peroxides. So in this peroxide-rich environment, the ability of acetaminophen fails as an anti-inflammatory drug. So these questions, you know, they are important as far as your exams are concerned, as far as your application or use of paracetamol is concerned. So such things would be important for your conceptual development. Now, all said and done, the NSAIDs inhibit the COX enzyme. And from these NSAIDs, paracetamol is different. I told you how it is different. Even aspirin differs from all other NSAIDs of its class. The reason is that aspirin is a hit and run agent. It inhibits the COX enzyme in the same way as all other NSAIDs do, but there is a difference. The inhibition of COX by aspirin is irreversible. That means if aspirin inhibits the COX, it is for the lifetime of the COX. If aspirin inhibits thromboxane A2, it is for the life of the platelet. So that is why aspirin is a hit and run agent. It covalently modifies COX-1 and COX-2, acetylates a serine residue in COX-1, and the duration of aspirin effects is corresponding to the turnover rate of COX in different target tissues. And that is the difference. All non-aspirin NSAIDs, they inhibit the COX competitively, and their course of action will be relating to the time the drug is in the body. For aspirin, we cannot say that even if aspirin is biodisposed of from the body, its effects are going to remain. And I would like to repeat here for our undergraduates that aspirin is a classical hit and run agent. Its most notable effect is on platelets, which being anucleate have a marked limited capacity for protein synthesis. So if aspirin inhibits the enzymes in the platelets, it is for the life of the platelet, and that is why with aspirin there is a chance of bleeding. There is a chance of bleeding, and inhibition of platelet COX-1 dependent thromboxane A2 is cumulative, and we start with the low doses and this effect is cumulative. So even if you miss aspirin for 1 or 2 days, the cardioprotection which it is offering in the form of prolonged bleeding time is not going to be affected. For the patient to recover from the aspirin effect, especially his platelets, it will take 8 to 12 days, and that is why prior to elective surgeries, the surgeons always advise to stop aspirin prior to surgery. That is only to decrease the risk of bleeding. Another important fact that why low doses of aspirin are preferred. Low doses, you know, they are generally safe to the gut and they do their job. What is the job? They have to cause platelet inhibition. They have to inhibit the COX in the platelet. So what is the unique sensitivity of platelets to low dose? Inhibition by low dose aspirin is related to their pre-systemic inhibition in the portal circulation before aspirin is deacetylated to salicylate on first pass through the liver. So in the portal circulation itself, when you are taking aspirin orally, that much of aspirin is sufficient to cause the inhibition of the platelet COX enzyme, and that is going to do the job as far as enhancement of the bleeding time is concerned. Once salicylic acid or aspirin enters the liver, It gets converted to another drug which is called salicylic acid, which is one of its metabolite, which does not have acetylating capacity. So this irreversible effect is experienced by the portal platelets more rather than the systemic platelets. And this salicylic acid does not have any acetylating capacity. It is also a weak, reversible, competitive inhibitor of COX. And that is what I said. It forms the basis for the use of the drug in prevention and treatment of arterial thrombosis. Now, these are the effects of various prostaglandins or products of arachidonic acid. Prostacyclin is a vasodilator, opposes platelet aggregation. Must remember this thing. Prostacyclin is a vasodilator, opposes platelet aggregation. And one thing I want to tell the students here is that this production of prostacyclin by the endothelium is dependent on COX-2. So that means both COX-1 and COX-2 are performing constitutive functions in the body. And that will also explain in a while, from 5 minutes from now, that why the selective COX-2 inhibitors are no longer used. Thromboxane A2 is a platelet aggregator. It is a vasoconstrictor. PGE2, it's an inflammatory mediator. PGF2 alpha causes bronchial constriction and vasoconstriction. And leukotrienes, I said, are mediators of inflammation. And the glucocorticoids, which you have already been covered in the endocrine pharmacology, they are even more potent in anti-inflammatory drugs as compared to the NSAIDs because they nip the evil in the bud. They inhibit phospholipase A2 in comparison to NSAIDs, which inhibits the COX enzyme only. So these are some general properties of NSAIDs. I told you, you must remember they are organic acids. They are getting well absorbed in the stomach because they remain unionized in the stomach and they have relatively low pKa values. All of them are well absorbed orally. They are highly bound to the plasma protein, so much so that aspirin can displace other drugs from its plasma protein binding sites. It accumulates in sites of inflammation where the pH is lower, potentially confounding the relationship between plasma concentration and duration of drug effect. So I can say with confidence that when you are giving NSAIDs, it does accumulate at the site of inflammation. It can be a joint inflammation where accumulation of NSAIDs in the synovium can also perform anti-inflammatory action, even if the drug is given systemically. These are the roles of prostaglandins for recapitulation. Prostaglandins participate in inflammation. They are mediators of pain. They mediate the rise in the body temperature. They cause dysmenorrhea. They're the reasons for causing painful periods, and they are involved in thrombus formation. Now this is an important slide because this slide will try to differentiate the COX-1 and COX-2 action. I would like to point out here that aspirin is an antipyretic agent. Aspirin is an anti-inflammatory agent was known since a very, very long time. But the mechanism action of aspirin, that it inhibits the COX and the COX-1 or the COX-2 was elucidated in the 1970s, 80s by John Wayne. So mechanism came out much later. The drug was being used much before its mechanism was elucidated. In the 1990s, the researchers felt that they have achieved a breakthrough. Most of the NSAIDs were non-selective inhibitors of COX-1 and COX-2. COX-1, if it was getting inhibited, of course, inflammatory prostaglandins were suppressed. I don't say no, but the GIT cytoprotection was compromised and platelet aggregation was compromised. If you see the COX-2 isotype, that was inducible by pro-inflammatory stimuli. At that point of time, the researchers thought that it is only COX-1 which is constitutive and COX-2 is inducible. But they were wrong. COX-2 and COX-1 both are inducible. COX-2 and COX-1, I would say, both are constitutive. COX-1 participates in the cytomucoprotective barrier of the stomach, participates in platelet aggregation. COX-2 constitutive functions are constitutive action in the kidney, number one. Number two, COX-2 is important for the production of endothelium-derived prostacyclin. If thromboxane A2 is platelet aggregatory, then prostacyclin is anti-platelet aggregatory. We have to understand this difference. COX-2 generally is inducible by pro-inflammatory stimuli, and it is maybe participating in inflammation, pain and fever. So the researchers felt that giving COX-2 inhibitors would do the job. Do the job in the way that COX-2 would suppress the prostaglandins at the site of inflammation. That is what we want. But because the drugs will be only COX-2 inhibitors, they would spare the COX-1. The COX-1 here was assumed as constitutive. So there was a time that these drugs, COX-2 inhibitors, were launched with so much pomp and show. They were given to many people who were suffering from osteoarthritis, rheumatoid arthritis, or any other musculoskeletal problem. They topped the list of orthopedicians, and they topped the list of many other prescribers. The COX-2 inhibitors were launched in the 1990s, late 90s, and in early 2003 and 4, there were reports of stroke, there were reports of MI, and there were reports of adverse cardiovascular occurrences in people who were taking COX-2 inhibitors. So what could be the reason? What could be the reason? A drug which was supposed to be the best drug for elderly population suffering from osteoarthritis could not stand the test of time. It could not stand the test of time. The reason was that once the COX-2 inhibitors were given, the COX-1 inhibition did not happen. Thromboxane A2, which was COX-1 mediated, was being formed. It caused vasoconstriction and platelet aggregation. Over and above, the prostacyclin, which was formed by COX-2, also suffered. And as we know that prostacyclin is anti-platelet aggregatory and vasodilator. So if we just inhibited the COX-2, it created a pro-aggregatory, pro-thrombotic environment in the body. And as a result of that, patients started complaining of stroke, patients started having increased incidences of myocardial infarction. Later on, rofecoxib was the selective COX-2 inhibitor, and it was withdrawn worldwide, and it was withdrawn by the Merck laboratories which synthesized it. So this was something which the medical fraternity took a long to take back and long to digest. So now whatever drugs we have presently are non-selective COX inhibitors. They might inhibit COX-1. You will get the GIT problem. You will be at a risk of bleeding. But again, you will have less risk of MI, stroke, and other pro-aggregatory adverse consequences. So this is COX-1 and COX-2 expression, primarily constitutive. COX-2 inducible expression, not normally present in most tissues, constitutive in parts of nervous system. But I would like to add here, it is constitutive in kidneys, it is constitutive as far as an endothelium is concerned, where it is responsible for the production of prostacyclin. As far as the tissue location of COX-1 is concerned, it has a more wide expression. COX-2 has more inflamed, expressed in the inflamed and activated tissues. And yeah, so those are the major differences. Another difference is that COX-2 is inducible by inflammatory stimuli. So there is generally no induction for COX-1, although we have the human chorionic gonadotrophin, which can upregulate it via the COX-1 in the amniotic fluid. And this was induced by the inflammatory cytokines, lipoprotein polysaccharides, tumor necrosis factor alpha, interleukin 1, interleukin 2, interferon gamma, etc., where the mRNA rises 20 to 80 fold and is regulated within 1 to 3 hours. So inhibition would be by non-specific COX inhibitors, and COX-2 will be inhibited definitely by the glucocorticoids. Actually, it inhibits everything. The Nsaids, especially the COX-2 selective inhibitors. Okay. So as far as the pharmacological effects of Nsaids are concerned, they have a very good analgesic action, but I can say they are reserved for mild to moderate pain. Of course, that is the pain of surgery or other types of pain of rheumatoid arthritis, etc. But yes, where severe pain abolishment is concerned, we have to rely on nothing except for morphine. When we are using the NSAID, we are telling the patient or giving a patient what do you call an opioid sparing strategy, because you can use the opioids, but they have limited availability. They have unwanted side effects of development of both physical and psychological, and also respiratory depression at therapeutic doses. As analgesics, they can relieve the inflammation which has been caused by peripheral or central sensitization of pain. It can relieve the post-operative pain. Pain arising from inflammation is controlled well. Pain arising from the hollow viscera is usually not relieved. So, it is not wise to give an NSAID for an abdominal colic or a biliary colic, anything, any hollow viscera generating pain. The NSAIDs are not the drugs of choice, except for the pain of dysmenorrhea, which originates from the uterus. Because the pain is linked to prostaglandin production, that is an exception. That's an exception. It does have anti-inflammatory action, but especially for rheumatoid arthritis, but we cannot just rely on the NSAIDs because they do not arrest the progression of the disease. And we do have other disease modifying anti-rheumatoid agents to take care of the same. Paracetamol especially has a very good antipyretic action. It resets the set point to the normal level and lowers the elevated body temperature in patients with fever by inhibiting the cytokine-induced prostaglandin synthesis. There's another subtype of COX which has been identified in the brain. It is the COX-3 which has been identified, and that is susceptible to inhibition by paracetamol. And these are the antiplatelet actions for which aspirin is topping the list of all prescriptions by cardiologists. And that is what we call the low dose aspirin, 75 milligram to 325 milligram of aspirin, which is given to patients who are having who are high risk for developing of cardiovascular complications. They are given aspirin, and this is because of its antiplatelet action only. Two debates are on. Ibuprofen interferes with the cardioprotective effects of aspirin when taken regularly. This is also a fact because ibuprofen and aspirin, they inhibit the COX enzyme. Aspirin inhibits the COX enzyme irreversibly. Ibuprofen does that reversibly. So when you are giving the two drugs concurrently, the COX enzyme is a limited enzyme. So aspirin will get some COX to inhibit, ibuprofen will also get some COX to inhibit, but to remember, to make you remind, ibuprofen causes irreversible inhibition of the COX enzyme. So as a result of that, the patient who is taking ibuprofen along with his low dose aspirin for musculoskeletal ailments, etc., might lose the cardioprotection which is offered by aspirin. Remember this thing. Remember this thing. Because ibuprofen will occupy the COX, leave the COX once it is biodisposed of from the body. And at that time, aspirin did not get so much of COX enzyme to act upon irreversibly. The second part of this slide would show that why the COX-2 inhibitors favored a more prothrombotic environment, that I already told you, that selective inhibition of COX-2 reduces endothelial prostacycling, allowing continued production of COX-1 derived thromboxane A2, and that led to a prothrombotic environment, increased risk of cardiovascular events, and that is the reason the drugs were withdrawn from the market, especially rofecoxib. There are other COX-2 inhibitors available still, celecoxib, but they are having very limited use. So now we know what is the difference between selective COX-2 inhibitors and non-selective COX inhibitors, and we'll try to recapitulate the major drugs here. It's better to be non-selective here. Aspirin, paracetamol, indomethacin, ibuprofen, phenylbutazone, no longer used. And we have the selective COX-2 inhibitors, rofecoxib, already withdrawn, celecoxib, etodolac, and nimesulide. Now, I would like to make the comment here that nimesulide is a preferential COX-2 inhibitor. A drug which is a preferential, not absolute COX-2 inhibitor means that at doses given, it might suppress the inflammation without causing less GIT toxicity. And nimesulide, caused less GIT toxicity. The prescribers tried to, capitulate on this point so much that tablet nimicin was one of the, again, a very favored drug which was prescribed by orthopedic. Syrup nice, was given by pediatricians to children so that their fever can come down. Syrup nice, nobody was giving syrup paracetamol. There was a time every pediatrician was relying on syrup nice. But syrup nice was not that nice. Not that nice. Because nimesulide led to increased risk of hepatotoxicity in children less than 5 years of age, and it caused sudden infant death in children less than 1 year of age. So this drug should be avoided in children. It might have no GIT toxicity. It might fare very well as far as lowering of fever is concerned. It might fare very well as joint inflammation is concerned, but it increases the risk of hepatotoxicity and sudden infant death. It is no longer to be safely given to children. Less than 5 years, this drug should not be given to children. Please remember this. As far as the clinical uses of these Nsaids are concerned, they are used for symptomatic relief in various arthritic conditions, rheumatoid arthritis, although I told you that we would need other drugs to take care of the inflammation in arthritis, which includes the corticosteroids as well as the disease-modifying anti-rheumatoid agents like methotrexate, hydroxychloroquine, and those drugs which will be taken later. These are excellent drugs, for reduction of fever. They're excellent drugs to treat your daily problems, headache, dysmenorrhea, all those. They are very good as far as prevention of adverse cardiovascular events are concerned. I would like to mention here the role of the low-dose aspirin, no other NSAID. Aspirin also has shown promising effects as far as delaying the damages in Alzheimer's dementia where it is concerned, and aspirin also decreases the risk of colon cancer, especially in those patients that this disease is more seen abroad in the West, where the patients already are candidates of, they already have familial adenomatous polyposis or FAP, which is a disease which is called FAP, and by the 6th decade of life, they inevitably develop the colon cancer. So aspirin might benefit these people who have taken long-term aspirin, and we might decrease the use or the development of colorectal cancer in patients who are sufferers or who already have familial adenomatous polyposis. These such questions, they can be asked in your NEET entrance, and these uses might not be so substantiated. Oh, that if you give aspirin, Alzheimer's will be reversed. If you give aspirin, patient will not develop colorectal cancer. No, it's not like that. But yes, there are some associations with the drug which we have to note, which are over and above their pharmacological actions or their pharmacological uses. So they have to be considered and remembered always. So that is it. It's an analgesic for mild to moderate pain. You can combine it with the opioids. We'll have for cancer pain as a opioid sparing strategy. As an inflammatory in rheumatoid arthritis, rheumatic fever, inflammatory joint conditions. I told you delays the progression of Alzheimer's, although we have other drugs which can decrease the effect on negative effects on cognition, like rivastigmine and tacrine, memantine also to some extent, which is an NMDA receptor antagonist. Continuing with the clinical uses, very good antipyretic agent. It is used for prophylaxis of ischemic heart disease to decrease the incidence of coronary artery disease. That is the purpose of low dose aspirin. It is used not only in the adults, but the neonates also find use if there is an inappropriately opened ductus arteriosus. It needs to close, especially in premature babies. So this drug is used to bring about the closure of the patent ductus arteriosus in the neonates. It can be used for systemic mastocytosis, which is a condition where there is excessive discharge of prostaglandins, PGD2, which causes a lot of flushing and a lot of, signs and symptoms of flushing is mostly seen, and that is because of the release of PGD2 from the mast cells. So that even if the PGD2 is released and if you have treated the patient with aspirin, the patient will not have such severe symptoms. Nsaids are also used to increase the niacin tolerability. Niacin is one of the lipid lowering agents. When you take niacin, it also releases prostaglandins in the body. Patient develops a lot of flushing and redness. So if you pre-treat the patient with an NSAID, he will be able to tolerate niacin better. And I told you aspirin is one of the drugs for cancer, chemo prevention, colorectal cancer. Cancer is the disease of the millennium, and there are very few drugs or very few studies which have been planned for the prevention. So one such drug which we say is aspirin for prevention of a particular kind of cancer, the colorectal cancer. Even nowadays they say metformin, you must have studied in diabetes. The oral anti-diabetic agent does have anti-cancer as well as anti-aging properties. So if these drugs can be studied by well-defined clinical trials, we would be having prevention for this deadly disease also. So now we come to the side effects. These are the group specific side effects of NSAIDs, and I told you many of it are related to the pharmacological action of the drug. That means they are all type A reactions, augmented predictable reactions. There is going to be NSAID-induced gastropathy in 40% of the users of NSAID. You might have experienced yourself. If you take 1 or 2 doses of ibuprofen, suddenly you start feeling heartburn, dyspepsia, and all those things start. Look at the people who have to take it daily, who are elderly in nature, who have had a history of an acid peptic disease. They are more susceptible to NSAID-induced gastropathy. Now, this NSAID-induced gastropathy might be due to the damage to the cytomucoprotective barrier, but it is also because of the iron trapping. Because these drugs are organic acids, they kind of accumulate in the gastric mucosal cell and they kind of reside there, damage the cell from inside, because they can go inside the cell because they are in an unionized form, but once inside the cell they become ionized because the pH inside the cell is alkaline relative to the pH in the stomach, as you know, is acidic. So that is the phenomena which is called iron trapping. You very well know the reason for NSAID-induced asthma. It is seen in 1 to 2% of the population, and it is because of the diversion of the products of the arachidonic acid pathway to the lipoxygenase pathway. There is more and more production of leukotrienes because prostaglandin pathway is blocked. And of course, we have NSAID-induced nephrotoxicity, and this demands a little more attention. But let us have the gastric damage. 15 to 40% will complain of dyspepsia. We have 5 to 18% with duodenal ulcers, gastric ulcers. 1 to 2% will have a GIT bleed, and you would be surprised to know that 40% of all GIT bleeds are attributed to NSAIDs. Of course, GIT bleeds can happen because of portal hypertension and bleeding esophageal varices. That could be one of the reasons, but NSAID use is also one of the reasons. And that is what I was talking about, the iron trapping. Remember this thing. The stomach pH lumen is 2 and the gastric epithelial pH is 7. So NSAID, like aspirin, which is a weak acid, will be in a non-ionized form in the stomach. It will try to go inside the cell, and you know it is a non-ionized form of the drug which can permeate the cell membrane. Once the drug is inside the cell membrane, it counters the pH of 7, which is an alkaline pH, and acidic drug is going to alkalinize in the basic pH, and then it is going to get trapped. It came inside, but it cannot go out. It came inside, but it cannot go out. So that is the reason for the iron trapping mechanisms. There are some established risk factors for GIT complications. There can be history of peptic ulcer bleed already in a patient, use of anticoagulants because they also enhance bleeding, use of 2 NSAIDs which include ibuprofen and low-dose amino aspirin, diclofenac and low-dose aspirin, already having a history of peptic ulcer, high NSAID use. Elderly, elderly are more prone to corona, they say. So elderly is a population which needs to be taken care of well, and that is why in the Western countries the branch of geriatrics is very well developed, and geriatric pharmacology itself is a separate shootout of our subject. But yes, they are vulnerable subjects, not only with respect to disease but also with respect to experiencing the side effects of the drugs. And if there is already a coexistent H. pylori infection, which is an independent risk factor for NSAID-induced injury, that could complicate the matters, and the use of glucocorticoids. So we can to some extent, we can prevent this GIT problems by giving a prostaglandin E1 analog, which is misoprostol. We can give a proton pump inhibitor, which will decrease the damaging effects of the gastric secretion on the already disturbed site of mucoprotective barrier. And we can give a COX-2 inhibitor. Of course, it's not a very wise option to give a COX-2 inhibitor because it is fraught with problems of MI and all. Not so easily available also now, but yeah, if you give COX-2 inhibitor, some of them are still available in the market. It will allow the COX-1 to function. It will spare the patient from the GIT side effects. So students, up till now we have covered the mechanism action of the NSAIDs in detail. We also try to differentiate between what is the essence of differentiating the COX-1 from COX-2. What is the reason the COX-2 were withdrawn from the market despite being a very successful agent as a pharmacological drug design is concerned, and what are the reasons for side effects with our NSAIDs. So its effects on the renal function and individual effects we would try to cover in the third sitting. And I hope you are enjoying this. And this has been specially done for students of NHL Medical College who we are not able to meet them longer because the classes are suspended owing to Corona. But yeah, we do miss them. Thank you so much.